I think a lot of dermatologists, their most angry patients of the day are those that come in with this nodulous cystic acne around the chin. It's a very high treatment rate. Usually 80% of the time they have failed multiple courses of systemic antibiotics, and even a third of the time they relapse on isotretinoin. So hormonal therapy is really good approach in terms of a long-term safe approach that's very effective in these situations. And hormonal therapy does have equal efficacy to oral antibiotics after about 6 months. And in particular, the nodulous cystic papules along the jawline, as well as these fine comedones on the forehead, can be a sign that the patient will respond well to hormonal treatment. In terms of the laboratory testing that the patients may be requesting, it's important to do hormonal testing only if you see signs of hyperandrogenism. So examples of this would be if there's hirsutism on the face, androgenetic alopecia at an earlier age, in their 20s and 30s, that they're developing a hair loss along the frontal scalp and the vertex of the scalp. Certainly, if there was any signs of virilization, that would be a very important patient to do hormonal labs. So that includes things like a deep voice or develop more of a muscular habitus. Infertility is also a sign, or having few to no periods, and also a sudden onset of very severe acne would also be reasons to draw laboratory exams. The most common example of a hormonal condition would be PCOS, which is polycystic ovarian syndrome. The Rotterdam criteria that were developed defines this as patients who have fewer than 8 periods a year. They have clinical or biochemical evidence of hyperandrogenism on lab tests that are done, and then also ultrasound findings that would be consistent with polycystic ovarian syndrome. The labs that the dermatologist should draw include a total testosterone. This elevation is very common, particularly in PCOS patients. If it's greater than 200, this would be indicating potential for an ovarian tumor. Also, free testosterone can be ordered, also commonly elevated in polycystic ovarian syndrome. The 17-hydroxyprogesterone, this is commonly elevated in congenital adrenal hyperplasia. And I think dermatologists often order a DHES level, which is very helpful. And greater than 8,000, this could indicate an adrenal tumor, anywhere from 4,000 to 8,000. And this is also a screening for congenital adrenal hyperplasia. Other labs that are helpful for hyperandrogenism include an LH and FSH ratio, where if it's 3 to 1 or greater, that's suggestive of PCOS. This is the luteinizing hormone relative to the follicle stimulating hormone. Prolactin levels can be done to look for a pituitary tumor, and also sex hormone binding globulin can be ordered. As we get older, this level, the SHBG, to increase over time. Oral contraceptive pills actually increase this as well. And this is inversely related to the development of type 2 diabetes. You want to have the patient obtain these labs on day 3 of their menstrual cycle in the early morning, because there's diurnal variation throughout the day. So you want it to be early in their follicular phase and in the morning. And they should be ordered 6 weeks after stopping any kind of hormonal therapy, because obviously any kind of hormonal therapy could change the blood work. Other relevant labs for patients with hyperandrogenism would include looking for metabolic syndrome. So for example, doing fasted insulin and lipids, or doing a cortisol level to look for Cushing syndrome, and find thyroid disease, do PSH to screen for thyroid disease, since this is a common cause of menstrual irregularities.